Please, I'd like to ask the speakers to come to the podium. Questions?
Yes, Dr. Walid.
Thank you. Thank you very much. Very excellent presentations. I have here, one comment, if you like, or question, mainly to Dr. Abdelhamid Hassan. Always when we talk about home blood pressure measurement, for me, to be honest, most of the time I tell patients, I don't like you to check your blood pressure, because most of the time it will be confusing to patient, confusing to doctor, and creating some problems. They don't know how to check it. They don't know how many times. They will be very upset and confused and on anxiety when they will have very variable blood pressure, high and low. It might be better if they will have ambulatory blood pressure monitoring, where we can have a mean evaluation of the blood pressure all through the day. Apart from just checking in the morning and checking after lunch and to have confusion, I don't like to do it. I know the guidelines, how it is like that. But in clinical practice and in our area, this is my feeling. Thank you.
Thank you very much. Yes, I agree. They said one of the drawbacks of home blood pressure measurement is the anxiety, and for sure it needs training, and the patient should measure in front of you or the nurse many times to be sure, and every few months he should repeat measuring in front of you or the nurse to be sure that he is measuring properly. And as I said, in ambulatory, I used to recommend every day ambulatory 24 hours blood pressure measurement for many patients. It is the gold standard for this. I agree with you. Thank you.
Next question. I hope that you are not sleeping. Still some more sessions to go. Yes, please.
Thank you very much, Dr. Morsaim, adult cardiologist. For Professor Wali, we notice as a cardiologist, we are not pulmonologists, we notice some important thing and we go us through it. So one concern about LVH, left ventricular hypertrophy in sleep apnea patient. We see in a lot of patients, sleep apnea, there is LVH electrically but not anatomically. Mean LVH ECG very clearly. When go to see this patient by echo, no LVH at all. And this arming us, we'll see, shall we start antihypertensive therapy, although the blood pressure is upper normal in patient with LVH electrically without anatomically? These points. Second one, sleep apnea, LVH, and the BiPAP or CPAP. Shall we go with patient with CPAP with LVH regression, and you notice in your practice the LVH go down? I'm not saying about reading. Last comment for our senior endocrinologist. As a cardiologist, we like to know something important about emergency in patient with aortic dissection. So the main issue here, please beta blockade this patient before vasodilating them, either by nitrate or nitroprusside. So the main message, don't vasodilate these people at all, except by beta blockade them first. Otherwise, you are go for more dissection. Thank you.
Sorry, can you repeat your second part of question loud? We didn't hear.
Yes, Dr. Kashkari, it's a comment rather than... Yes, it's a comment rather than a question for you. But the question is for Professor Wali.
If you can repeat it برضه كان كويس لي أنا. الصوت فيه مشكلة في الميكروفون. If I understand your question correct, you're asking if there's a relationship between sleep apnea and left ventricular function?
There is LVH, electrical LVH. When they look at the echo, there is no real LVH. But by ECG, there is like signs of LVH. So shall we treat those patients with borderline hypertension or pre-hypertension with obstructive sleep apnea? Am I saying the question correctly?
Well, I need the expertise of the cardiologist. they would decide. But if there is a discrepancy between the echo finding and ECG finding, it's none of my business. This is the cardiologist's business to decide.
Yes. About CPAP and regression of LVH, you get crossed?
Yes, actually, CPAP, well, observational studies only show that CPAP does improve the ejection fraction even. But this need more studies to confirm that. There are many studies in favor of CPAP as a preventive treatment for even cardiovascular complication and to treat even congestive heart failure. By giving CPAP, you reduce the afterload. By giving CPAP, you decrease the preload as well. Theoretically, it works, and literature-wise, there are few studies supporting it, yes, but I think we need more studies to make it clear-cut. Yeah.
Dr. Noel, can I just
Yes,
add?
we'll take only 2 short questions, okay?
Okay. I'll just do the second comment was Dr. Kashkari. The second comment was giving beta blocker before giving vasodilators in patients with aortic dissection. The doctor here is suggesting that you have to beta blockade them, give them beta blocker rather than give them vasodilator first in cases of aortic dissection. So do you have any comment on this?
Your question is regarding aortic dissection. So aortic dissection is a very serious condition with high mortality, and the blood pressure should be lowered immediately. That's an exception to a level less than 120 systolic within 30 minutes. Because if you don't do that, you might lose the patient. The standard recommendation is, because you want to lower the blood pressure immediately, you use nitroprusside but with beta blocker. But there are alternatives. I show them in the slide. You can use also nitroglycerin or other drugs in combination with beta blocker. And Orapidil, this new drug, as I mentioned, is also an alternative in this condition.
Okay. Last question, please.
Portable device for hypertension. This one should, as the Holter ECG, should be under the supervision of the treating doctors. Is it like this? And should be provided by, I don't know, hospital administration or MOH or something like this. I think it is not just put and go and come.
So is your question to Dr. Abdel Hamid Hassan?
You heard the question? Can you repeat it, Dr. Nawal, because I did not hear the question?
Yes. Can you repeat your question, please? I did not hear you. The mic with you is not good.
For the automated portable device for control for measures of hypertension at home or at market or anything should be under the supervision of one of the doctors, the in charge doctors, to give him the device, to apply it and to follow it. Like the Holter ECG, just don't give and go and get. No, it should be under supervision of cardiologist, the one, and the other one under the in charge doctors. This is the first one. The second one for my colleagues, Dr. My friend, inshallah. The question, what are the differential clinical situations in our emergency and the urgency? One or two clinical, tell me please, other entity, clinical entity. In differential diagnosis. Because emergency, you have to start, admit them into ICU or CCU and start immediately. IV, antihypertensive drugs.
Okay.
This is for emergency. For urgency, you can give oral, but again, in a close observation and setup.
Yes.
ICU or
yes, okay.
anything like this.
Yes, Dr. Abdel Hamid. Dr. Abdel Hamid Hassan.
They need training, like ambulatory blood pressure monitor. You should not
The question.
ask the patient to measure the blood pressure. You should train him
For ambulatory blood pressure measurement, we send him to cardiology unit. They will educate him, train him, show him the machine, when to remove it if he is going to take shower, and when the blood pressure the machine is inflating, what to do during sleep. It is everything is covered in the cardiology unit, and the report will come from cardiologist to my clinic after analysis.
Regarding the hypertensive emergency and urgency, the question was, is there a possibility to do a differential diagnosis on in the emergency room on clinical ground? So it is possible if you have experience and if you keep quiet, no hectic, make sure the blood pressure is really high, and make sure the patient has severe symptom. If the patient is having severe symptom like neurological deficit, hemiparesis or so, that is an emergency. If he has severe dyspnea, that's with pulmonary edema possibly, that's an emergency. If he has chest pain, I mean additional with high blood pressure, that's emergency. They have severe symptom usually, and they have life-threatening symptom. The majority of the patient presenting in the ER, 75%, they are not emergency. They present in the ER with non-specific symptom, like chest, like headache, like a little bit unwell feeling. Those patients, you have more time. But when the patient presents with symptom suggesting emergency, like acute chest pain, acute dyspnea, acute neurological deficit, those patients should be treated immediately. I hope I could answer your question.
Okay. Probably you can continue the discussion later on because we have to move on. Now, I'd just like to invite Professor Wali for a small appreciation from SHMS.